usually when we talk about diagnosing a major medical transition, there's this expectation of precision.
Right, yeah, like checking your cholesterol or something.
Exactly. You get a little blood drawn, the lab runs the numbers, a doctor looks at a printed sheet, and it's definitive, black and white, high or low.
I mean, we are entirely conditioned to trust the lab report. It feels objective, it feels scientific, and frankly, it's just comforting. We desperately want a concrete number to point at.
We want to know exactly what is happening inside our bodies. But welcome to today's deep dive, where we are looking at something that completely shatters that expectation.
For you, our favorite curious listener, our mission today is to cut through the confusion.
Yeah, we're diving into the exact official diagnostic criteria that clinicians use to confirm a woman has reached menopause.
And we are pulling from a heavy stack of gold standard sources for this. We've got the National Institute for Health and Care Excellence, along with the British Menopause Society, and the European Society of Human Reproduction and Embryology.
The actual rule books, basically. Right. And most people assume menopause is diagnosed with that definitive blood test. But the reality is wildly nuanced. It is heavily dependent on age, and what truly shocked me in our research today, in a massive percentage of cases, it involves absolutely zero lab tests.
Which goes against almost every instinct a modern patient has when they walk into a clinic. I mean, they want the blood panel, they want the proof.
Okay, let's unpack this, because what I found in these medical guidelines completely upended my expectations.
If we connect this to the bigger picture, we really have to clarify early on that these diagnostic criteria are not just, arbitrary bureaucratic hurdles.
Right.
They are carefully designed clinical guardrails. They exist to prevent unnecessary medicalization and to avoid plunging women into unwarranted anxiety over fluctuating lab numbers.
So let's anchor this in the most common scenario first. We're looking at women over the age of 45. Statistically, the average age of menopause in the UK is 51, right?
Yeah, 51, with the normal biological window spanning from around 45 to 55.
Okay. So if a woman falls into this over 45 demographic, the official diagnostic criteria completely abandon the laboratory. It's an entirely symptom-based diagnosis.
Completely. There is zero ambiguity in the guidelines on this point. For an otherwise healthy woman over 45, no blood tests are required.
Wait, no blood tests at all? I mean, in modern medicine, we test for everything. You complain about a lingering cough, someone is running a panel.
I know, it sounds almost negligent at first glance.
Right. Yet for a massive systemic hormonal shift that reshapes cardiovascular health, bone density, and neurological function, the gold standard is just to ask her how she feels.
But there is a profound biological logic to it. To understand why the lab tests are totally useless here, we have to look at what the criteria actually tell doctors to look for. The guidelines separate this into two phases.
Perimenopause and menopause.
Exactly. Perimenopause being the turbulent lead-up.
So the guidelines state a clinical diagnosis of perimenopause is confirmed by the new onset of vasomotor symptoms alongside irregular periods.
Yeah, and vasomotor is a very sterile clinical term.
Very sterile. We are talking about the body's internal thermostat just going completely haywire. The classic hot flushes and night sweats.
The underlying mechanism there is fascinating, honestly. As estrogen levels begin to behave erratically, the hypothalamus, which is the part of the brain that regulates temperature, it just gets confused.
It thinks you're overheating.
Right. It suddenly thinks the body is overheating. So it triggers an emergency cooling response. The blood vessels in the skin rapidly dilate, which gives you the flush, and the sweat glands go into overdrive.
Wow.
So if a woman over 45 describes this happening and her periods are losing their predictable rhythm, the doctor has all the information they need. That is a clinical diagnosis.
And then we hit actual menopause, which is notoriously diagnosed in the rearview mirror. The guidelines define menopause as 12 consecutive months without a menstrual period, assuming the patient isn't on hormonal birth control, of course.
Yeah, you have to factor that in.
But why the 12-month wait? Why not 3 months or 6 months?
Because the ovaries do not power down in a linear fashion. They sputter. I mean, you might go 7 months without a cycle, and then suddenly an ovarian follicle matures, produces a massive surge of estrogen, and triggers a period.
Oh, wow. So you're back to square one.
Basically, yeah. Historically and statistically, 12 months is the biological safety buffer. Once a woman crosses that specific threshold, the probability of spontaneous ovarian activity drops to near absolute zero.
I really want to dig into this sputtering concept because this is the exact reason the guidelines forbid the blood test for women over 45. The test everyone asks for is the FSH test, right? follicle-stimulating hormone.
Yeah, it's heavily marketed online, but testing FSH in a 48-year-old is essentially an exercise in futility.
Why is that?
To see why, you have to visualize the communication loop between the brain and the ovaries. FSH is the chemical messenger from the pituitary gland. It's basically yelling at the ovaries to get to work, to mature an egg and produce estrogen.
Right, but if the ovaries are aging and becoming resistant, they don't listen very well.
Precisely. They ignore the signal, estrogen stays low, the brain senses this, panics, and yells louder. It pumps out massive amounts of FSH.
So logically, if a doctor sees sky-high FSH on a lab report, it means the ovaries are failing, which points to menopause. It sounds like the perfect biomarker.
If the ovaries were completely and permanently dead, yes. But during perimenopause, as we established, they sputter.
Right, the 12-month rule.
Exactly. So the brain yells, the FSH spikes, but then suddenly a rogue follicle decides to respond. It pumps out a massive wave of estrogen. That feeds back to the brain, and the brain says, oh, look, they're working.
And abruptly drops the FSH levels back to normal.
You got it. And this wild fluctuation can happen from week to week or even day to day.
Okay, relying on a single FSH test during perimenopause is like, well, it's like trying to determine the climate by taking a single temperature reading during a wild thunderstorm. It's fluctuating far too much to be useful.
That is the perfect analogy. If a doctor draws blood on a Tuesday, the FSH might look completely normal. On a Thursday, it might be off the charts.
And the danger of that normal Tuesday reading is immense.
No, it really is. Because if the lab report comes back looking fine, an uneducated clinician might look a suffering woman in the eye and say, well, your blood work says you aren't in perimenopause.
Which is just awful. That false negative completely invalidates her lived experience. It tells her the debilitating brain fog and night sweats are in her head.
And it drastically delays her getting hormone replacement therapy or other vital support. Treating the patient's actual symptoms is infinitely more important than treating a number on a lab report.
Yeah, if she is 48 and waking up drenched in sweat, she needs clinical intervention. The thunderstorm thermometer reading from that morning is irrelevant.
The guidelines are effectively mandating that doctors must trust the patient, period. Her subjective experience is a more highly calibrated diagnostic instrument than the lab equipment here.
Okay, here's where it gets really interesting. Because the tension between objective data and subjective experience completely flips when we adjust the timeline. The moment a patient is younger than 45, the medical guidelines revoke that trust-based approach.
Yeah, the rule book changes dramatically.
It really does.
Yeah.
Why does age change everything in these guidelines?
Well, it has to change. Menopause occurring between the ages of 40 and 45 is clinically categorized as early menopause. It impacts about 5% of women.
Okay.
And biologically speaking, an ovarian shutdown at 42 is profoundly different than at 52.
So the guidelines for this 40 to 45 bracket state that clinicians can no longer rely on symptoms alone. They must see the irregular cycles, they must hear about the hot flushes, and indeed they're medically required to get biochemical confirmation.
Right, the FSH blood test suddenly becomes mandatory.
But notice how they deploy it. Knowing that FSH is a volatile, sputtering metric, a single test is still considered medically useless.
What's fascinating here is that they require 2 separate blood draws showing elevated FSH.
But the detail that really stands out here is the mandatory waiting period. The guidelines strictly dictate that these 2 tests must be performed 4 to 6 weeks apart. Why the mandatory waiting period? If a woman is suffering from severe hot flushes, doesn't that delay her getting help?
It goes directly back to your thunderstorm analogy. Because the ovaries can sputter and have these bursts of activity, a single high FSH reading could just be a fluke.
I see.
They need to prove they're measuring a permanent shift in the climate, not just a passing weather event. The 4 to 6 week gap proves a sustained decline in ovarian function.
So if the FSH is high in week 1 and still high in week 6, it suggests the ovaries haven't just taken a temporary nap, they've permanently retired.
It is about establishing a definitive trend line, but, you do have to acknowledge the human cost of this requirement.
Yeah. Sitting in a waiting room for a month and a half while your body is aggressively malfunctioning sounds like absolute torture for the patient.
It really does.
You're having 15 hot flushes a day, your sleep is destroyed, and the doctor says, come back in 6 weeks and we'll see if you qualify for help.
It is incredibly frustrating, and many specialists argue it borders on cruelty. But the alternative, misdiagnosing early menopause, carries a very heavy burden.
Because of the long-term health risks.
Exactly. A diagnosis of early menopause means committing a woman to a much longer lifespan without the protective benefits of natural estrogen. That extended deprivation accelerates bone density loss, dramatically increases the risk of early onset cardiovascular disease, and impacts cognitive health.
So the clinicians must be absolutely certain before putting a younger patient on a lifelong high-dose hormone replacement pathway.
They have to be.
Wow. And if the stakes are that high for a 42-year-old, they must be catastrophic for someone in their 20s or 30s.
Which brings us to the most rigorous, stringent diagnostic criteria in all of these documents, women under the age of 40.
Yeah, and when menopause occurs before age 40, it sheds the term menopause altogether. The official medical diagnosis is premature ovarian insufficiency, or POI.
And how common is that?
Depending on the data set, it affects between 1 in 100 to as many as 4 in 100 women. The criteria for diagnosing POI are intense. The doctor must observe disordered menstrual cycles, so absent or highly irregular, for at least 4 months, and they still require that double biochemical proof. Elevated FSH levels on 2 blood samples taken 4 to 6 weeks apart.
Right.
But wait, earlier we established that official menopause requires 12 months without a period. For POI, the guidelines only demand a 4-month wait. They are severely compressing the timeline.
That compression is highly intentional. Waiting a full 12 months to officially diagnose a 32-year-old woman who has virtually zero circulating estrogen is just medical negligence.
Because of the bone loss.
Exactly. Every month she goes untreated, her bones are literally thinning, and her cardiovascular risk is mounting. The 4-month rule is an aggressive attempt to intervene faster.
But even within these aggressive guidelines, the scientific community can't seem to agree on the actual math.
No, they really can't.
This is where the tension between different medical societies really bubbles up. We are looking for elevated FSH, but the European Society ESHRE defines elevated as anything over 25. Meanwhile, the British Menopause Society points to a threshold of over 40. Why can't the most prestigious medical bodies agree on a single number?
It just highlights the sheer complexity of endocrinology. Hormones do not operate like digital light switches. They exist on a messy biological curve.
Right.
An FSH reading of 25 indicates the ovaries are in severe distress, but a reading of over 40 indicates almost total, absolute shutdown.
It sounds like different medical bodies have different risk tolerances for false positives versus false negatives. The European guidelines are willing to catch women slightly earlier in the decline.
Whereas the British guidelines want undeniable proof of total failure.
Exactly. And the British guidelines also suggest looking at estradiol levels, which is the primary form of estrogen. If FSH is over 40 and estradiol is rock bottom, it paints a very clear picture.
But they are careful to note that low estradiol alone cannot be the sole diagnostic tool, right? Right, because estrogen levels fluctuate just as wildly as FSH in the early stages of failure.
Okay, so in reading through all of these diagnostic sources, another acronym aggressively popped up. AMH, or anti-Müllerian hormone. If you've ever looked into private fertility clinics, you've definitely seen AMH marketed as the ultimate egg timer test.
Oh, absolutely.
But the clinical guidelines throw cold water on that.
Oh.
They explicitly ban the use of AMH as a primary diagnostic tool for premature ovarian insufficiency.
This is a vital nuance. AMH is produced by the tiny, immature follicles resting in the ovaries. So a severely low AMH score definitely suggests a depleted ovarian reserve.
Okay.
But diminished reserve is not the same biological state as total insufficiency. A woman can have an undetectable AMH level and still occasionally ovulate and menstruate.
So relying on AMH is essentially like looking at a backup generator. You don't rely on it as your primary source of power or your primary diagnosis, but it's there if the main system fails to give a clear answer.
That's a great way to put it. It provides context, but not confirmation. The guidelines state it should really only be used as a tiebreaker if the FSH results are inconclusive.
Got it.
The reason these primary tests are so strict is because diagnosing POI requires the clinician to act like a detective. They have to systematically eliminate every other physiological reason a young woman's reproductive system might have stalled.
You can't just assume ovarian failure. You have to rule out everything else.
Right. Pregnancy is obviously the very first thing to check, but they also must rule out severe thyroid dysfunction, hyperprolactinemia, and polycystic ovary syndrome. Misdiagnosing a thyroid issue as irreversible premature menopause would be devastating.
Yeah, that would be awful. But there is one glaring exception to all this biochemical detective work in the under 40 group. The guidelines outline an automatic POI diagnosis for any woman who has undergone a bilateral salpingo-oophorectomy before age 40.
Yeah, that is the surgical removal of both ovaries. It induces what is termed surgical menopause. In this case, the biological machinery has been physically removed.
So no blood tests are needed.
Not at all. There is no need for a 4-month waiting period or an FSH test. The diagnosis is immediate, and the hormone replacement therapy should theoretically begin on the operating table.
So up to this point, we've been treating the human body like this perfectly readable, transparent system. Track the bleeding, measure the hormones, map it against the age bracket.
Right.
But human biology is incredibly messy, and modern medicine constantly manipulates it. What happens when the biological data is chemically masked?
This is where the diagnostic guidelines really have to bend to accommodate the reality of modern women's healthcare.
Let's start with structural masking. What if a woman simply doesn't have a uterus? Say she had a hysterectomy in her late 30s to resolve fibroids, but the surgeons left her ovaries intact.
Which is pretty common.
Right. She turns 48 and starts feeling horrific. She physically cannot fulfill the 12 months without a period rule because she doesn't have the organ that bleeds.
For women over 45 without a uterus, the guidelines revert back to pure, unadulterated symptom presentation. Since the visual marker of the menstrual cycle is gone, the clinician must rely almost entirely on the onset of menopausal symptoms.
Like the hot flushes.
Yeah, the vasomotor symptoms or genitourinary changes like severe vaginal dryness or recurrent urinary tract infections.
But the much more insidious diagnostic blind spot involves exogenous hormones medications that actually alter your baseline chemistry. We are talking about the combined oral contraceptive pill, hormonal coils, or someone taking high-dose progestogen.
This is a major stumbling block for the biochemical criteria. Women utilizing these hormonal therapies simply cannot be accurately diagnosed using an FSH blood test.
Because the synthetic hormones are constantly suppressing the natural levels, right?
Yeah.
They are chemically overriding the communication loop.
Exactly. The synthetic estrogen and progestin trick the brain into thinking the ovaries are functioning perfectly. So the brain never panics. It never pumps out that surge of follicle-stimulating hormone.
Oh.
If you draw blood from a 42-year-old woman who is actively taking the combined pill, her FSH will look artificially suppressed and totally normal, even if her ovaries are actually in the process of failing.
So what does this all mean? The medication effectively masks the biological markers of menopause. So theoretically, if a woman is on the pill in her late 40s to manage heavy bleeding, could she transition entirely through perimenopause and into postmenopause without ever officially qualifying for a lab-based diagnosis until she stops her medication?
She absolutely could. It is a very real quirk in the medical guidelines. To get an accurate, unmasked FSH reading in a younger woman suspected of early menopause, she must stop taking all hormonal therapies for at least 6 weeks prior to the blood draw.
We are back to that agonizing 6-week waiting period.
Yeah, unfortunately.
You're asking a patient to intentionally induce a 6-week hormone withdrawal, which could trigger a brutal return of heavy bleeding, debilitating cramps, or violent hot flushes, just to get a clean lab reading.
Which is exactly why the most skilled specialists don't rely solely on the math. When a patient's natural hormones are masked, the clinician is forced to take a truly holistic history.
They really have to listen.
They do. They can't rely on missed periods or lab values. They have to listen for the subtle systemic shifts. Unexplainable fatigue, a sudden onset of debilitating anxiety, severe joint pain, or new onset sleep disturbances.
It underscores how reliant this entire diagnostic process is on a robust, trusting conversation between the doctor and the patient. You can't just glance at a spreadsheet of lab values. You have to interpret a complex constellation of human experiences.
Exactly. If a clinician is rigidly only looking for a checklist, the classic hot flush and a missed period, they're going to fail a massive percentage of women.
It really is staggering how customized this all has to be. Let's synthesize what we've unpacked from these medical guidelines because it completely reframed how we should view this transition.
Yeah.
The official diagnosis of menopause is a highly tailored, age-dependent protocol.
Very much so.
If you are over 45, the rules demand trust. It is a symptom-based diagnosis where blood tests are heavily discouraged because fluctuating hormones render them useless.
But the moment you drop under 45, the diagnostic gates slam shut. The guidelines demand rigorous, repeated biochemical proof. Those two elevated FSH readings spaced 4 to 6 weeks apart alongside missing periods.
To protect against premature health risks.
Right. That strictness isn't there to dismiss the patient. It's there to secure undeniable proof before committing a young woman to a lifetime of critical cardiovascular and bone-protecting therapies.
And if your biological markers are chemically masked by contraceptives or physically altered by a hysterectomy, the entire rulebook adapts again. heavily relying on the clinician's intuition.
You know, this raises an important question to leave everyone with. We are moving rapidly to an era of algorithm-based healthcare.
Oh, definitely.
We have artificial intelligence scanning our medical charts, we have wearables on our wrists tracking heart rate variability, and tech companies promising that a complex blood panel can diagnose our entire future.
We want the math. We want a machine to spit out a definitive answer.
But if AI and algorithms require clean, objective, black and white data to function, how will they ever handle the diagnosis of menopause?
That's a great point.
This is a biological event characterized by messy, fluctuating data, chemically masked markers, and a gold standard of care that relies entirely on the oldest medical tool in the book. A human doctor looking a woman in the eye, listening to her describe her lived experience, and simply believing her.
It makes you wonder if an algorithm could ever replicate the empathy and intuition required to actually get this diagnosis right, or if other areas of medicine might benefit from returning to this symptom-first approach. It's a fascinating tension to leave you with. Keep questioning the lab reports, keep tracking your own normal, and keep demanding those nuanced conversations. We'll see you on the next deep dive.